Good afternoon, everyone, and thank you for joining us in this Webicon brought to you by Cardinal Santos Medical Center. I am Dr. Michael Louis Gimenez, your caring cardinal neurosurgeon and your moderator for today's session. As a neurosurgeon, I specialize in the diagnosis and surgical treatment of diseases of the brain and as well as the spinal cord. For today's session, we will hear from our experts from brain-inspiring tumor management at Cardinal Santos. We will also hear about the story of one of our patients who has experienced firsthand the services, processes, and procedures we will be discussing today. Hopefully, from his perspective, we can all learn about what truly matters when it comes to caring for one's health and well-being. After that, we will open the floor for questions. We would like to ask everyone to stay thereafter after the open forum for our group photo op to commemorate this event. Just some reminders for this Webicon. First, may I remind all panelists to mute your microphones during the session to avoid distracting our speakers. For the open forum, please type your questions using the Q&A function of Zoom. And finally, after the session, please take time to give us your feedback about this Webicon by logging on to www.menti.com using the code 38038109. You may also access the evaluation form, which will be sent to you after the session. Time and again, I have seen how the discovery of a brain and spine tumor has caused anxiety and even turmoil to a patient and his or her family. There is always a frantic search for information, expertise, and guidance to understand the disease, its implications, and the best way to treat it. Having a brain or spine tumor at the most unexpected time can really be terrifying and most definitely life-changing. Here at Cardinal Santos, we have multidisciplinary care focused on effectively managing these diseases. For any given case, our doctors collaborate and work together day in and day out to come up with the best possible treatment options to save a life and to make a difference. In an effort to raise awareness about the importance of gathering medical experts with different specializations in treating brain and spine tumors, Cardinal Santos Medical Center is holding a Webicon entitled, "It Takes a Village to Save a Life," a Webicon on the multidisciplinary approach to brain and spine tumor management. Part of our advocacy is to make quality and innovative healthcare accessible to everyone. Hence, an initial primary goal is to educate you about these diseases and the life-saving services that are available at your disposal. At this point, let me make a short segue on how Cardinal Santos Medical Center has become a cornerstone and a center of excellence in the management of neurosurgical diseases in the country. The CSMC Brain and Spine Institute was the very first institute established in Cardinal Santos. 2 decades into its inception, it has made Cardinal Santos a center for advancements and innovations in the field of neurosurgery in the country. The vision started with this man, the late Dr. Eduardo Reyes Mercado, a pillar in Philippine neurosurgery, a past medical director, and my neurosurgical partner for 13 years. One by one, he worked to bring in state-of-the-art treatment options for varying neurosurgical diseases. It started with the Philippine Gamma Knife Center, the recognized gold standard in stereotactic radiosurgery worldwide. It allowed a less invasive treatment option for brain tumors and other brain pathologies. This will be elaborated on by one of our esteemed speakers later on. This was followed by another breakthrough center in 2005, the Philippine Movement Disorder Surgery Center, or PhilMove. The following year, my colleagues, Dr. Jet Aguilar and Dr. Ted Vesagas, with their formidable team, performed the very first deep brain stimulation for Parkinson's disease in the country. To date, Cardinal Santos remains to be the authority in the surgical management of movement disorders in the Philippines. Fast forward to 2008, again, under the brilliant visionary guidance of Dr. Mercado, the Multidisciplinary Brain and Spine Tumor Center was established. Amongst its goals, to form a team of experts of varying subspecialties geared towards the ideal management of brain and spine tumors. The process we had to go through, as well as our regular activities, will be elaborated as well by our next speaker. To date, we have 8 centers under the Brain and Spine Institute, making it a bastion of care for various neurosurgical and neurological diseases. By late next year, we are eyeing the establishment of a world-class epilepsy surgery center. At this point, I will now give you a short talk on the signs and symptoms of brain and spine tumors. So what is a brain tumor? It is defined as the growth of abnormal cells in the brain and can develop in any area of the brain. Curiously, there are over 120 types depending on their origin and behavior. And like any other tumor, it can be benign or malignant. Now, this artwork shown here was done by an artist named Sean Thornton. He's based in Philadelphia, and he believed that his artwork alluded to the presence of a cancerous brain tumor. He was correct. Doctors eventually found a mass in his pineal gland. He had treatment and is presently doing well. This slide will show you the common signs and symptoms of a brain tumor. I will be touching on these individually and in the process elucidate facts from fiction. Headaches would be the most commonly associated symptom to brain tumors. Headaches by itself is rarely caused by a brain tumor. The chance that your headache is a sign of a brain tumor is very remote. However, it may be the presenting symptom in 25% of brain tumors, and is usually a manifestation of increased pressure from tumor growth and swelling. This is a representative MRI showing a large frontal lobe tumor surrounded by perilesional edema, which of course obviously exerts significant mass effect on the brain parenchyma. Now, what would characterize headaches that would require immediate medical care? Progressive headaches, particularly those associated with a decrease in the frequency and intensity of the attacks, is a red flag. Headaches associated with severe nausea and vomiting Headaches associated with neurological symptoms such as a hemiparesis or weakness of one side of the body, or visual changes are likewise red flags. Headaches that worsen with exertion or physical activity such as sneezing and coughing should also be considered highly suspicious. Nausea and vomiting is a usual sign of increased intracranial pressure from an enlarging tumor or a tumor involving structures near the vomiting center, which is called their area prostrema, and it is located in the hindbrain or the back part of the brain. Brain tumor symptoms can present as vision problems, such as blurred or double vision, abnormal eye movements, and restricted field of view. They are typically progressive and occur at a fairly accelerated rate compared to your typical degenerative conditions. It may arise from two causes: from increased pressure in the brain, causing swelling of the optic discs, or from compression of specific brain structures subserving visual function. Now, these are key structures in different areas of the brain that may cause varying degrees of visual loss. As you can see, it is not limited to the eye or the optic nerves, but can also involve the temporal, parietal, and the occipital lobes where you have your primary visual cortex. So any tumor in those areas can cause visual problems. One of the more common locations for brain tumors would be the pituitary area here, which can cause the typical peripheral loss of vision. This is because of compression of the structure called the optic chiasm, which is where your optic nerves meet. And typically, they would cause loss of peripheral vision, as seen in this perimetric study, wherein you have loss of vision on the periphery of your right eye as well as the left eye. Used interchangeably with convulsions and epilepsy, a seizure is defined as the physical changes in behavior that occur after an abnormal electrical activity in the brain. Convulsions, on the other hand, refer to the uncontrollable shaking that is rapid or rhythmic with the muscles contracting and relaxing repeatedly, while an epilepsy is a term used once a patient has repetitive episodes of seizures, hence the term epileptics for those who have recurrent seizures. Just some trivia. It is a little known fact that while Saint Valentine is widely associated with love and Heart's Day, he is also actually the patron saint of people with epilepsy. Seizures present in several ways. The more typical ones would be uncontrolled jerking movements of the extremities, which may be associated with loss of consciousness. It may likewise present as blank stares, accompanied by episodes of temporary confusion, and other less common manifestations, such as cognitive, emotional, or even sensory symptoms, like having an abnormal swell, etc. Some important facts about seizures. Again, most seizures are not caused by brain tumors. Seizures from brain tumors are usually focal in character, meaning only one side of the body is usually affected initially, but it can be generalized to involve both sides of the body. What is considered a red flag is what we call late onset seizures or epilepsy, which would be defined as seizures in adults for the very first time. This should now raise the suspicion for a possible anatomic cause, such as a stroke or a tumor, which would eventually lead to an imaging study. Balance problems are secondary to impingement of brain structures that control coordination. Because of the typical tumor location, it may also be accompanied by dizziness and cranial nerve dysfunction. What are cranial nerve dysfunctions? It may be numbness of the face, weakness of the face, hearing loss, and swallowing and speech problems. Involvement of the cerebellum, which is an important structure for balance and coordination, is a common cause of balance problems. In this example, you have a tumor in the cerebellopontine angle. This is the cerebellum, This is the pons, it is at that angle. So by affecting the cerebellum, it will cause balance problems, but it will also cause cranial nerve problems because of the involvement of the hearing nerve. So you will have visual loss and even facial numbness, and a late sign would be facial weakness. Drowsiness or coma is usually from progressive increase in intracranial pressure or from development of hydrocephalus, which, as you know, is excess water in the brain caused by blockage of flow, and one of them would be a tumor. It is usually a late sign and is a slow process compared to the drowsiness or the coma that you would expect with other diseases in the brain, such as a stroke. Another symptom that is infrequently caused by brain tumors but should not be overlooked would be personality or behavioral changes. This would occur from tumors arising in the frontal lobes, particularly if both frontal lobes are involved. Let us now go to spine tumors. As a background, the most common tumors would involve the bony structures, and these are called extradural tumors, and they would involve bone. Quite commonly, you would also see intradural, extramedullary tumors. They are within the dura, the covering of the brain and the spinal cord, but outside of the substance of the spinal cord. The rarer tumors would be intramedullary, which would involve the parenchyma of the cord. In terms of the signs and symptoms, the most common would still be pain, which would usually be at the site of the tumor due to tumor growth. It can likewise present with radiating pain from the back to other parts of the body, like the arms or the legs. Back pain is typically worse at night. The symptoms may be associated with loss of sensation or muscle weakness, especially in the arms and the legs. There may be difficulty walking, and sometimes this may cause falls. Now, most back pain, again, is not caused by tumors. But because early diagnosis and treatment would be essential, you have to see your doctor if any of these would present or would characterize your pain. If it is persistent and progressive, it is mechanical in nature, meaning it is associated with movement, with ambulation. If it gets worse at night, and if you have a history of cancer and develop new back pain, because this may point to a metastatic lesion from your cancer that would commonly go to the bones, more commonly the spine. Paralysis. Compared to the brain, paralysis from cord lesions would usually involve both sides, both arms and both legs, although they are asymmetric, meaning one side would be worse than the other. And this is usually accompanied by numbness or sensory disturbances. And it may be accompanied by changes in bowel or bladder function. I think that's my last slide. So again, thank you very much. Okay, from here on, we will now be discussing the treatment options in managing brain and spine tumors. Our next speaker will talk about the concept and processes of a multidisciplinary approach, and after this, discuss a breakthrough technology that allows non-invasive treatment of brain tumors. He's one of the prominent and sought-after neurosurgeons in Cardinal Santos, whose leadership and passion for neurosurgery is an inspiration for doctors and patients alike. He is the clinical director of the Institute's Brain and Spine Tumor Center and the Philippine Gamma Knife Center. He is also the current executive secretary of the Philippine Board of Neurological Surgery, the certifying body for neurosurgical trainees in the country. He has authored several noteworthy publications in international peer-reviewed journals and is currently the editor-in-chief of the Philippine Journal of Surgical Subspecialties. Lastly, he is considered one of the foremost authorities in stereotactic gamma knife radiosurgery in Asia, having performed over 3,000 of such cases. Currently, he sits as a board member of the Asian Lexcel Gamma Knife Society. Ladies and gentlemen, it is with much pride and honor to present to you Dr. Theodor S. Vesagas to talk about a team approach to brain and spine tumors and stereotactic gamma knife radiosurgery for brain tumors.
Thank you, Mike, for that introduction. Let me just start my slide. Okay. Magandang hapon po. Today, I'm going to be covering two topics. First is the team approach to spine tumors. And after this, I'm going to be talking about, or at least giving an introduction to gamma knife radiosurgery. Our first topic will be about the multidisciplinary team approach to brain and spine tumors. We're a long-standing multidisciplinary team. It was established, as Dr. Mike said, in 2008. And it's one component, the Brain and Spine Tumor Center is one component of the Brain and Spine Tumor Center. Since our establishment, we've been a very staunch advocate of the multidisciplinary team approach. The Brain and Spine Tumor Center has, over the years, held symposia promoting the MDT, or the multidisciplinary team approach, in Metro Manila, in places like Davao, in Clark, Baguio, Subic, Bacolod, and other parts of the country, aside from Metro Manila. Last year, the different centers of the Brain and Spine Institute had a combined meeting with experts from all over the world. Now, this is a snapshot of our Brain and Spine tumor team at one of our meetings. This is obviously pre-pandemic, as nobody is wearing masks and there's no social distancing. Today, our meetings are held on Zoom. So we are a group of healthcare professionals of different disciplines who work together to uncover the best possible solutions for our patients who have complex medical conditions, since we're dealing mostly with cancer and brain tumors. The team's strength lies in our ability to commit more knowledge and experience to a problem than any single member can do, acting alone. So I guess the first question is why? Why do we need a whole group of people to take care of just one patient? Magusot at pinsang masalimuot ang paggamot ng mga cancer o bukol sa utak at gulugod. And this is just a short list of possible healthcare professionals that might be required to help a patient. There is truly potential for miscommunication, poor coordination, and even misunderstanding. It's like basketball, parang basketball siya. You can have stars, you can even have superstars on a team. But often, it's a team that works together, that displays teamwork, and makes proper use of the talents of each of its players that often wins the day. So what is this multidisciplinary process? It happens in 3 stages. Nauna ang pagkonsulta ng isang pasyente sa kanyang manggagamot or attending physician. The physician will discuss the diagnosis and stage of the disease, and they will talk about the possible cures or possible remedies. Also discussed will be the viewpoint of the patient and the patient's family. Yung pangalawang hakban, or the second step, is the multidisciplinary conference itself. The attending doctor presents the case to the team, and our team, who has specialists in neuroradiology and neurology, both adult and pediatric, oncology, both adult and pediatric, radiation oncology, neurosurgery, and neurosurgeons of different specialties. We have spine surgeons, surgeons like myself who do a lot of radiosurgery, surgeons who do open surgery, who do open awake surgery. So we have a whole, and we even have skull-based surgeons. So it's a whole gamut of specialties in neurosurgery. Of course, we have a neuropathologist and other specialists. The members discuss diagnostic and therapeutic possibilities from their unique viewpoints. And the patient's views and preferences are always considered when recommendations are made. The process finishes with the third step, which is feedback to the patient. So this is another meeting between the attending physician and the patient. And they talk about the conference and what the uh, recommendations at the conference are. And hopefully, armed with data and the team recommendations, the patient and the family can come to an informed decision of what they think is best for the patient. This is a quick summary of those 3 steps. Our objective is for comprehensive care. We have to remember that when we consider brain and spine tumors, treatment can come in the form of operative surgery, maybe gamma knife radiosurgery, radiotherapy, chemotherapy, immunotherapy, and precision oncology. Or it could be a combination of all of these. At ang pagtitiempo nito ay maaring papalit-palit at paiba-iba batay sa mga pangangailangan ng mga pasyente. Now, treatment is not the only objective. Our treatment also monitors progress, discusses biopsy findings, which affects how we have to evaluate response. We also treat complications of treatment and consider palliative options for patients who have severe disease or advanced disease. How does the patient benefit? Well, it does shorten time from diagnosis to treatment. You can think of it as one thing when a patient is presented, then all the specialists know about the case since we've talked about the case. And so it's easy for us to get from diagnosis to treatment much more quickly. There's a greater likelihood of receiving consistent and timely care, and patient care is managed by a team. And this increases patient satisfaction with the care. In the end, we want to provide the best possible care for our patients who are afflicted with tumors of the brain and spine. At this point, let me segue to the oldest multidisciplinary team in the Brain and Spine Institute. This is the Gamma Knife Center, or the Philippine Gamma Knife Center. So these are the questions which I hope to be able to answer with this portion of the talk. What is gamma knife radiosurgery? How is it done? What are its applications? What are the benefits and risks? How does it compare to open brain surgery? And where can gamma knife radiosurgery be done? Gamma knife radiosurgery. Minsan po itinatawag itong SRS or radiosurgery. Was invented by this fellow here, a Swedish neurosurgeon named Lars Leksell. Talking about him and how this developed, stereotactic radiosurgery developed to be a long lecture in itself. But suffice to say that as a young neurosurgeon in the 1930s, he was bothered by how high the risk was for undergoing brain surgery. At that time, in the 30s, 3 out of 10 patients would probably not survive the surgery. And he sought to reduce the hazards of open brain surgery by delivering maybe a high dose of radiation. This was not radiotherapy. He used a very high dose of radiation to destroy any deep structure without risk of bleeding or infection. And in the 1950s, you see in this picture here, was the first version of the gamma knife, which found clinical use in Sweden. Now, he achieved this high dose by focusing, for lack of a better term, many small beams of radiation into a small defined volume. Now, stereotactic radiosurgery has evolved since then. And in this very long definition, I'd just like to emphasize here in red that it is a multidisciplinary team consisting of a neurosurgeon who leads the team, a radiation oncologist, and a medical physicist that manages the procedure. Now, this is a picture of the team with the late Dr. Eduardo Mercado. And this is our state-of-the-art gamma knife, the Gamma Knife Perfection. So how is gamma knife radiosurgery performed? How is it done? The workflow is actually just in 4 steps now. First, we attach a stereotactic frame to a patient's head. The frame serves as the landmark by which we base all our measurements. The second part, the patient undergoes digital imaging, and this can be in the form of an MRI scan, a CT scan, or digital angiography, or a combination of these, depending on what the patient's problem is. We then program the machine for our target. whether it's a tumor or vascular malformation or a functional target. And finally, once the programming is set and transferred to the machine, the patient is treated. We set up the patient in the Gamma Knife. The treatment bed is robotic. So after we set him up, the machine just follows our program and goes through with the treatment. The actual procedure is actually painless. This slide summarizes the broad applications of Gamma Knife radiosurgery. We can treat tumors, both benign and malignant. There are certain vascular diseases of the brain that we treat, and there are functional indications like pain from trigeminal neuralgia. Gamma Knife to treat movement disorders, obsessive compulsive disease, and some forms of epilepsy are being performed in other centers abroad. But today, we're just going to be talking about the tumors, the benign and malignant tumors, and just a small subset of these. So, since we started in 1998, we've had performed over 3,000 cases already, and almost 700 of these are vascular, close to 2,000 are benign, and nearly about 500 of these are malignant tumors. Now, talakayin muna natin ang dalawang pinakamadalas na nakikitang benign tumors. Now, what are benign tumors? Benign tumors do not spread, but they have a tendency to enlarge and cause damage. The two most common are meningiomas, which we will be talking about first, and vestibular or otherwise called acoustic schwannomas. So, meningiomas are tumors that arise from the tissue covering the surface of the brain and the spine. They're often benign, but rarely there are some aggressive variants. Now, these tumors can be found either close to the surface, as seen here, or nestled deep within the skull. Now, this is an example of a deep meningioma. This is what we describe as a petroclival, because it's in the petrous bone and close to the clivus. And the picture on the right here is the treatment after Gamma Knife after 6 months. This is another deep meningioma. And we can see here on top the treatment day, followed by 1 year and 3 years after. The goal or the objective of Gamma Knife radiosurgery is to control or stop the growth of a tumor. Over time, some tumors may even get smaller. We have treated close to 900 patients with meningiomas at our center. And this is our usual dose here. And we've achieved close to a 95% control rate that we've recorded. Now, the image on the right shows a meningioma closer to the surface of the brain, at which we've been observing for over 4 years now. And we can see it's slightly smaller at the 4th year. From meningiomas, we can move on to another very common benign tumor, the vestibular schwannoma. These tumors arise from the 8th nerve, or the nerve that conducts impulses for hearing and for balance. These tumors are also generally benign. This is a patient with a small schwannoma treated and followed over an 8-year period. So you can see here treatment, 4 years and 8 years after. This is a slightly larger tumor, maybe not slightly, but a larger tumor at Gamma Knife treatment, and at 5 years later. And then we can see how the tumor has shrunk after treatment. Now, we have done a little over 400 cases of vestibular schwannomas. Our tumor control rate is about 95%, give or take, and the rate of cranial nerve complications is low. The image on the right shows a patient which we followed for over 4 years now. So at treatment, this is, I think, 2 years and 4 years after. Now, the second group of tumors we will cover are the malignant tumors. These are more common. The most common of these are the brain metastases. And of this kind of tumor, we've done over 350 cases. Now, a brain metastasis is a cancer that spread to the brain from a primary or original site. This happens in about maybe 17 to 20% of cancers. Some will report slightly higher. They're more common in lung cancer, in breast cancer, and a form of skin cancer called melanoma, though in Filipinos, this is a little less common. Cancers from the kidney and the gut have been also observed to metastasize to the brain. Now, unlike benign brain tumors, metastasis can be complex to manage. You have to consider the source or the primary tumor. You also have to consider sites of spread or the secondary sites, like the skeleton, the liver, the lungs. And as far as the brain is concerned, what's the most appropriate kind of treatment, all things considered? Would surgery be the most optional treatment, optimal treatment? Would whole brain radiation be a treatment? Or would gamma knife radiosurgery be the treatment of choice? This is where a team is truly required and appreciated. At the Gamma Knife Center, we have about an 85% control of solitary or single metastases. These pictures below are of metastasis from a patient with brain cancer, roughly 1 year apart. Our control will drop to about 80% when we deal with multiple metastases. If we talk about survival, that is affected by many factors, not the least of which is the nature and the status of the primary disease. For solitary lesions or single lesions, we can offer gamma knife radiosurgery if the target is smaller than 3.5 centimeters in diameter, and if the primary is known. For multiple metastases, the number of lesions is not as important as the aggregate volume of the lesions. Usually we look at maybe 15 and to 20 cubic centimeters tops. For a patient undergoing surgery, we usually will recommend focal treatment of the tumor bed to prevent recurrence. This is a picture of a vestibular neuroma we've now been following for over 10 years now. And this is a very good result. You see here from treatment and yearly after that, you see shrinkage and finally at this point, static, the tumor stopped growing. But there are situations where radiosurgery might be limited or may not be the best option. One limitation of radiosurgery is we don't have a biopsy, we have no histopathology. So if a lesion, especially if the lesion presents in an unusual way, either by having an unusual history, so a lesion that might look benign but has a very fast history, or have an unusual physical exam or strange looking imaging, we may often suggest either a surgical option to either remove the lesion or take a biopsy of the lesion. We, as a rule, do not treat large targets like this with single session radiosurgery. For lesions like this, where you have brain compression, extensive brain compression, we usually will say that surgery would be a better solution for this issue. Finally, we have to be able to deliver an effective dose of radiation. And there are some structures in the brain that will not tolerate radiation well. And these include the brainstem and the optical nerves. And so if the target is too close to these, like this, radiosurgical procedures may not be feasible. Now, to wrap up this talk, these are the advantages of gamma knife radiosurgery. It is cost effective. When we tell you it will cost so much, it will really just cost so much because you won't end up with an extended stay in the hospital. It affords a good quality of life. It allows maintenance of functional status. It allows treatment of lesions usually not amenable to surgery, and allows excellent control with minimal morbidity. This can also preclude delays in chemotherapies for patients with tumors of the brain, who require chemotherapy. If we do a gamma knife procedure, you can finish it in 1 day and proceed with other treatments that are necessary. Now often these gamma knife procedures are performed on an outpatient basis. So this small graphic below shows a sort of a comparison between gamma knife and open surgery. So from symptoms to diagnosis, if you have open surgery, you will, after surgery, will probably stay a couple of days in the ICU and maybe a couple more days, maybe a week or 2 in the hospital recovering, and maybe another month and a half convalescing at home. If you do a gamma knife radiosurgical procedure, you can actually go back to work the next day or the day after. The final question is, where can gamma knife radiosurgery be done? Now, the gamma knife is the gold standard upon which other radiosurgery machines are measured. And I have to emphasize, there's only one gamma knife in the Philippines, and it's here at Cardinal Santos Medical Center. But more importantly, the gamma knife is a tool. And more than looking at the tool, you have to think about the people who use the tool. Our multidisciplinary team has over 24 years of experience, of know-how, and has experience with over 3,000 cases and probably more than 4,000 procedures. So this is the place to take them for radiosurgery. I'd like to thank you for your time and your listening.
Thank you very much, Dr. Ted, for sharing with us how the multidisciplinary team approach works and how gamma knife radiosurgery has really become a beam of hope for a lot of our brain tumor patients. If I may add, the gamma knife helps us because if we can only take out part of the tumor, we can actually use the gamma knife as an adjuvant tool to take care of the remaining deep-seated tumor. But what if the gamma knife is not for you? Are there any other procedures that can be considered for treatment? I'm certain that some of you remember Patrick Dempsey in Grey's Anatomy, Richard Schiff in The Good Doctor, or even Benedict Cumberbatch as the mortal neurosurgeon before he became Dr. Strange. For sure, you have wondered if what they did in the OR was really fact or fiction. Our next speaker will elucidate on this for you, and he will be touching on the other innovative options of neurosurgical treatment, not only for the brain, but likewise for spine tumors. He's an active consultant at Cardinal Santos Medical Center and with other hospitals in the metro. With his desire and commitment to expand education and training opportunities for young aspiring doctors, he has been appointed as a training officer for Cardinal Santos Medical Center's Spine Fellowship Program, the training officer for the University of Santo Tomas Hospital's Neurosurgery Residency Training Program, and is an assistant professor in the UST Faculty of Medicine and Surgery. His special field of interest is in the field of minimally invasive spine surgery, and he is a prime mover of the Cardinal Santos Spine Center, one of the centers under the Brain and Spine Institute. To talk about the state-of-the-art surgical management of brain and spine tumors, please welcome my neurosurgical partner, Dr. Gilbert Rañoa.
Thank you, Mike. I'll just share my screen. Okay, good afternoon, everyone. So my topic is state-of-the-art surgical management of brain and spine tumors. And let me begin by giving you a very brief description of what tumor is, okay? Well, a tumor is basically an overgrowth of tissue that can occur in any part of the body. It usually presents as a lump if it's superficially located, that you can palpate it, and it can be classified as benign or malignant, as what Dr. Gimenez mentioned earlier. You describe this as a benign tumor when it's slow growing, and you describe it as malignant either when it is fast growing or when it has a tendency to spread in other parts of the body. Now, brain and spinal cord tumors are also known as CNS or central nervous system tumors because the brain and spinal cord do belong to the central nervous system. And these tumors in general have certain peculiarities. While majority of the CNS tumors in adults are malignant, benign tumors do predominate in children and the pediatric population. Now, whether they're benign or malignant, CNS tumors can compress the brain and spinal cord and produce stroke-like symptoms because of compression. And they can cause headaches, difficulty in speech, and weakness. Now, there are many misconceptions regarding tumors in general. So let me try to discuss and clarify some of these myths. One of the more common questions that I've been asked regarding tumors is that, is it hereditary? Although a small percentage of tumors have genetic predisposition, majority of them, whether benign or malignant, are actually sporadic, meaning to say you don't get them from your parents, and therefore they're non-hereditary. What about stress? That's another very pertinent concern, especially during this time of the pandemic when everyone is really stressed. Does it have something to do with tumor? And the answer is simply no. Stress has nothing to do with tumor development. Now, what about cell phones and other gadgets that emit electromagnetic field? These gadgets also have nothing to do with tumor development. Tumors are basically non-transmissible. They're not infectious unlike your COVID. And fortunately, they're not work-related. Now, again, because of the advent of the pandemic, a lot of people would ask, is this related to vaccine? Well, we know that vaccine, specifically COVID vaccines, have certain side effects, but up to now, science has not proven any correlation to development of tumors. So that's another no. Now, I know this has been discussed earlier, but just let me go through this. I have just have one slide regarding signs and symptoms. Well, generally for brain tumors, you can have headaches, vomiting, seizures because of brain irritation, and weakness. For spinal cord tumors, you can also have weakness. Generally, you can have numbness, which will usually coincide with a level of spinal cord involvement. But the most common presentation of spinal cord tumors would be back pain. For the diagnosis, it is the MRI with contrast. It is considered to be the diagnostic imaging of choice for brain and spinal cord tumors. At times, though, your attending may request for other diagnostic imaging, such as a CAT scan or a PET CT, or they may even request for blood tests, which may include tumor markers. Now, they can use this screening, or they can use this for monitoring purposes. Now, generally, there are three ways of treating tumors, and they are through surgery, or through radiation, or through chemotherapy. Now, I'll be limiting my talk to surgery, and chemotherapy and radiation will be discussed by the other speakers. So going back, why surgery? Well, surgery has the following roles when it comes to brain and spinal cord tumors. And the first is actually the most important, which is providing histopathologic diagnosis. This is obtained by getting a piece of tumor and having them examined under the microscope. You have to understand that different tumors are treated differently. So it is a must that we have to identify the exact name of the tumor. And that is basically the start of the management or the whole treatment of your patients with tumors, diagnosed with tumors. Second is surgery can palliate symptoms from local tumor effect. If you remember one of the earlier slides that I've shown you, whether benign or malignant, tumors can compress the brain and spinal cord and cause symptoms. So when you do surgery, you take out the mass effect, and therefore it follows that by doing that, you can alleviate the patient of the compression symptoms. Third, obviously, when you take a tumor, you take out tumor cells, and that should provide better tumor control together with the other adjuvant treatments. Adjuvant meaning to say whether you need radiation or chemotherapy. Now, this should equate to better or improved survival and a better quality of life for your patient. Now, when we're performing surgery, especially on these delicate organs, and we're dealing with brain and spinal cord, it is imperative, of course, that safety should be our topmost priority. I think that's a given. And fortunately, at Cardinal Santos Medical Center, we have the state-of-the-art equipments that can or that allows us to safely perform advanced surgeries for patients with brain and spinal cord tumors. So in the next few slides, I'll be enumerating the surgeries that we can do and the advancements or state-of-the-art technologies that we have at Cardinal Santos. So let us begin with our operative microscope. Obtained by the hospital in 2019, July of 2019, this operating microscope, it's a Gimenez 900, remains to be the latest and most advanced operating microscope in the country. It has a robotic visualization system that basically delivers a lot more positioning precision. And the microscope features a point lock system which enables a surgeon to observe a larger area inside a smaller cavity. Now, this is particularly helpful when you're doing minimal access surgeries or surgeries with small openings. Now, operating through the oculars of a microscope can be quite uncomfortable for surgeons, especially after 5, 6, 7, or even longer hours. Now, fortunately, high definition 3D exoscopic surgery is feasible in our operative setup. This allows surgeons to operate while looking at 3D screens instead of the oculars of the microscope. So that is what you see in this picture. That is me and Dr. Gimenez doing exoscopic surgery. You have to wear, I don't know if you noticed, it looks like shades, but it's actually goggles. Those are actually 3D goggles. So that when you look at these 3D screens, you'll have depth perception. And you need that when you're doing surgery. Now, during the start of the pandemic, this exoscopic surgery setup became really very useful. If you look at the left lower part of the screen, again, that's Dr. Gimenez and I doing surgery on a COVID suspect patient with our full PPEs. We obviously cannot use the microscope because of our full face masks, and it prevents us from looking into the oculars or the eyepiece of the microscope. Now, fortunately, with the help of the company that provided us the Gimenez, we were able to mount a 3D film into our face mask and eventually allowed us to perform exoscopic surgeries. And we were able to not to compromise a patient with this kind of visualization. So we were able to use good visualization despite the pandemic. Now, one of the caveats of using a microscope is that its view is limited to a straight line of sight, missing information behind tissues and corners. Now, the solution is this. It's a Kivo micro inspection tool. It's basically a tool that has a camera at the tip. For those of you who are familiar with an endoscope, this basically acts like one. And with this tool, we can easily inspect crevices and hidden areas for residual tumors. So we can go back. Once we put this in, we see a residual tumor, we can go back and do a better excision of tumors. Now, let me talk about the yellow 560. Certain tumors of the brain and spinal cord may be difficult to distinguish from normal tissue, even under microscopic view. So fortunately, at Cardinal Santos Medical Center, we have the yellow 560 filter. It is a filter attached to the microscope that allows you to view a special dye as it lights up tumor tissue. What you see in this picture is actually a deep-seated tumor under the yellow 560 filter. Now, as I've said, some tumors are just too difficult to distinguish from normal brain tissue. If you look at the picture on the left, there's actually tumor there surrounded by normal brain. Now, if you're not a neurosurgeon, it will be probably difficult for you to identify it. And let me show you the tumor. So that is your tumor. Now, it takes experience actually to identify these tumors. And some of the examples of these tumors would be your gliomas. It's a benign tumor. Now, fortunately, with the yellow 560, identification of the tumor is made much easier. Now you look at the picture on the right, if we turn on the yellow 560, the tumor would just light up, and excision will therefore be much made easier. We also have a special filter that we use to assess blood vessels in the brain called the Flow 800. Although its main use is when we're operating on aneurysms and AV malformations and other abnormal vasculature, we sometimes use this to assess patency of the blood vessels that we manipulate when we're operating on tumors. Now we go to another machine, the surgical navigation system. At Cardinal Santos, we use the Stealth Station S8 by Medtronic. It's a computer-based operating room machine that allows surgeons to precisely track instrument positions and project them onto the preoperative imaging data. Simply put, this is the GPS tracking device inside our neurosurgical suite. So that's me using the navigation system. And because this equipment guides surgeons like me to where the exact location of the tumor, we can now be more precise, come up with better planning, and make smaller incisions and do minimally invasive surgeries. It's the same system, or it's the same machine that we use or spine surgeons use when they're removing a spinal cord tumor or doing stabilization surgery, as what you see in this picture. It is most useful when surgeons are inserting pedicle screws or implants in very small bony targets. Now, integrating our navigation system with our microscope even provides more features. If you look at the picture on the left, that's a microscopic view of a tip of the tumor protruding through normal brain tissue, with majority of the tumor still underneath the normal brain. So once the integration setup is activated, the picture on the right is what we see. So I don't know if you see my cursor, but this is now the tumor underneath that brain. Okay, let's go back. So underneath that brain, and we can make our approach a lot easier even without cutting through the brain. We can also put or incorporate the yellow 560 filter and project the contour of the tumor that is hidden under the brain. So different combinations that we can use. Now, identification of important fiber tracts of the brain is one of the more amazing features of our navigation system. The picture shows a low-grade glioma. That's a huge picture on the left, showing a low-grade glioma. That's a kind of benign tumor, and its relationship to some of the fibers responsible for speech. The right lower picture, you see Dr. Ted Vesagas doing a preoperative plan, identifying the critical fibers that we may encounter during our surgical approach. Now, another procedure that we do at Cardinal is a stereotactic biopsy. A stereotactic biopsy is a procedure wherein a neurosurgeon sticks a needle into the brain to obtain tissue diagnosis. At Cardinal Santos Medical Center, we use the Gamma Knife facility for the Lexel frame placement and target planning. So all those computer work are done at the Gimenez Center. Now, having done over 300 biopsy procedures, the stereotactic biopsy team at Cardinal Santos Medical Center is the most experienced biopsy team in the country. Nowadays, because we have the navigation system, the biopsy team actually has an option of doing this procedure without the application of a head frame. Another procedure that we do at our center is awake craniotomy. Awake craniotomy is a type of procedure performed on the brain while you are awake and alert. It is usually done in patients with brain tumors that are located in eloquent areas. Surgeons wake up the patients during the procedure to make sure that normal function, such as movement and speech, is not compromised during tumor removal. Awake craniotomy can only be done if an intraoperative neurostimulator is available. And this is what we use at Cardinal, the Nimbus Eye Care. So inside the awake craniotomy, we ask the patient to do certain tasks. For this one, is a finger tapping, just to make sure that function is preserved. This is the awake craniotomy team consisting of surgeons, several neurosurgeons. You have the neurologists, our neuroanesthetists. Now, the same machine also doubles up as an intraoperative neurophysiological monitoring device. It is what we use to monitor cranial nerves, especially the facial nerve, when we excise tumor in the cerebellopontine angle area. It is now known that the use of these intraoperative monitoring device can significantly reduce the incidence of facial nerve paralysis in as much as 50% in these types of surgeries. So this is basically what it sounds like. And once we hear this sound, that sound, once we hear that very loud sound, we know that the facial nerve is very near, and we'll try to shy away from that direction. So going back, intraoperative spinal monitoring is also available at our center with the help of our neurophysiologists. Not only is it helpful in spine tumor surgeries, but also in other spine procedures such as scoliosis surgery, which is performed by our orthopedic colleagues. And still on spine, minimal access surgeries are usually performed, whether it be because of tumors or other causes such as degenerative diseases. This is made possible again because of the availability of minimal access retractors and surgical equipments designed for small openings. You can't do these types of surgeries when you don't have the proper equipment. Now, this is what our operative suite looks like in a typical spine procedure. The patient lay down using a special spine table at the center with the operative team, the intraoperative monitoring or the IOM and the neurophysiologists would be on one side. In this case, they're on the left. And the navigation system will be on one corner, and the operating room technicians prepare the microscope at the other end of the room. All of these state-of-the-art equipments are available only at the operating suites of Cardinal Santos Medical Center. These technological advancements we combine with the expertise and experience to give our patients the Cardinal Santos care that they truly deserve. Thank you very much. That'll be my last slide.
Thank you, Dr. Gilbert, for expounding on the various state-of-the-art tools that have allowed us to perform more efficient, effective, and of course, safer surgeries for our patients. We will hear more from Dr. Ted and Dr. Gilbert during the open forum part of our session today. Moving forward to our next speaker, she serves as the Dynamic Director of the Cancer Institute of Cardinal Santos Medical Center. She is also the president of the Philippine Alliance for Brain and Spine Tumors Incorporated, a foundation that we established more than a decade ago, which is geared towards helping the indigent community who are afflicted with this condition. In her quest to further understand and advance breast and lung cancer, its management and treatment, she's currently involved in several phase 3 clinical trials in the country and has published and presented various scientific papers in medical oncology. To talk on the non-surgical management of brain tumors, one of the super women in our team, please welcome Dr. Maria Luisa Abesamis-Tiambeng.
Thank you, Mike, for the kind introduction. Allow me to share my screen. Can you see it now?
Yes, Malu, we can see your
Thank
screen.
you. Thank you, everyone. It is an honor for me to be part of this team, and we have saved many lives by the grace of God and because of the unique relationship that we have with each other. So after learning about the high-tech surgical toys of our neurosurgeons, allow me now to discuss with you how we can shrink brain tumors without cutting you up. First, some basics. What is cancer and why is it deadly? Cancer is simply put an accumulation of abnormal cells that don't follow the rules. The rule for normal cells is they multiply when needed and they die when they get old or damaged. Cancer cells multiply at an abnormal speed and avoid dying. So they crowd out the normal cells and eventually damage the body. Brain tumors can either be benign or non-cancerous or malignant, cancerous, as was already discussed by the previous speakers. They can start in the brain, called primary brain tumors, or come from other parts of the body, called secondary or metastatic brain tumors. They are also classified according to their cell of origin or their grade. The higher the grade, the more aggressive they are. More recently, we have been able to classify tumors according to their genetic makeup using biomarker or molecular testing. Some of these tests are called immunohistochemistry or fluorescence in situ hybridization or FISH, which looks for variations in the number of copies of a particular gene. Others are called PCR or polymerase chain reaction, which looks for changes in a particular section of the DNA. And there are others that are called DNA sequencing, which looks for an abnormal DNA code. With the help of these tests, we are able to identify the genetic mutation present in each tumor and prescribe a drug which specifically targets such mutation. Regardless of the type of tumor, whether benign or malignant, big or small, tumors in the brain can be potentially devastating because damage to even the smallest part of the brain caused by such tumors can leave us unable to speak, comprehend, remember, move, or see. So much has already been said about the 3 pillars of brain tumor management and why we need a multidisciplinary team to create and execute a comprehensive management to such a complex disease. If there is anything we want you to take home with you after this webinar, you only need to remember 3 letters, MDT. Demand it from your doctor. Your life or the life of your loved one depends on it. Aside from gamma knife radiosurgery, CSMC is also equipped with the latest linear accelerator or radiation therapy machine that can treat patients not eligible for gamma knife radiosurgery over a span of days or weeks, also called fractionated radiotherapy. And of course, the last, but certainly not the least modality to be utilized for brain tumors is chemotherapy, or more aptly called systemic therapy, since the use of drugs or medicines to treat cancer is no longer just limited to cytotoxic conventional chemotherapy. Nonetheless, classical cytotoxic chemotherapy are still the most commonly used drugs for brain tumors, particularly temozolomide, lomustine or CCNU, and procarbazine. Targeted therapy is very effective for patients with SEGA or subependymal giant cell astrocytoma and brain metastasis coming from EGFR or ALK positive lung cancer, HER2 positive breast cancers, renal cell cancers. Immunotherapy, on the other hand, has made great waves in the management of systemic cancers, but is still considered experimental for primary brain tumors. Cytotoxic chemotherapy, the classical one that we know, works by attacking certain phases of the cell cycle. And usually, they cause damage to the DNA of the cancer cell, leading to cell cycle arrest or death of the cancer cell. A perfect example is temozolomide. It is the most commonly used oral chemotherapy for primary brain tumors. Temozolomide or TMZ is an oral alkylating agent that is lipophilic, allowing it to pass through the blood-brain barrier. Once inside the brain, it releases its active metabolite, MTIC, which then incorporates itself into the DNA of the cancer cell, leading to cell death. Targeted therapy, on the other hand, exerts its damaging effect on the cancer cell by blocking or inhibiting specific receptors or enzymes that lead to the growth and proliferation of the cancer cells. This cartoon illustrates how a monoclonal antibody to epidermal growth factor receptor, cetuximab, inhibits downstream signaling mechanisms that lead to cell proliferation, angiogenesis or new blood vessel formation, and survival. Anti-angiogenic drugs, exemplified by bevacizumab or Avastin, is technically also a targeted agent as it inhibits the vascular endothelial growth factor or VEGF responsible for formation of new blood vessels that supply the tumor, in this case, the glioblastoma. We have seen remarkable responses in recurrent glioblastoma patients given Avastin, even just after one cycle, as you can see in this remarkable response illustrated by the patient's MRI. Immunotherapy, one of the biggest breakthroughs of the 21st century, works by stimulating the body's own immune system to fight cancer. The discovery of immune checkpoint inhibitors, such as pembrolizumab, gave scientists James P. Allison and Tasuku Honjo the Nobel Prize for Medicine in 2018. These drugs work by inhibiting the inhibitors of T-cell activation, thereby leading to tumor cell destruction. Most chemotherapy, including targeted and immunotherapy, is given intravenously or by mouth. Temozolomide, the most common cytotoxic chemotherapy for brain tumors, is given by mouth. A few drugs, such as methotrexate, can be injected directly to the cerebrospinal fluid via spinal tap, or a reservoir placed inside the ventricle called an Ommaya shunt. This is what we call intrathecal or intraventricular chemotherapy. Chemotherapy drugs are usually given in cycles. What is a cycle? It is the time period over which the chemotherapy is given, including rest periods. This allows the cancer cells to be attacked at their most vulnerable times and allows the body's normal cells to recover from the damage. Temozolomide, for example, is given every 4 weeks, lomustine every 6 weeks, and bevacizumab every 2 weeks. So why are we giving chemotherapy when we know that the most effective way to treat a brain tumor is to remove it? Because for many of these tumors, recurrence is the rule a few months to a few years after surgery. So science had to find a way to delay it, if not completely prevent the onset of this recurrence. Listed here are some of the most common CNS tumors in which the use of chemo makes a difference in terms of preventing or delaying recurrence and prolonging life. glioblastoma, anaplastic astrocytoma, oligodendroglioma, low-grade gliomas, medulloblastoma, and ependymoma. How do we know these drugs work? That is now the role of the clinical trials. Clinical trials testing the efficacy of new drugs and new modalities tell us whether they do make an impact in the lives of our patients in terms of progression-free and overall survival. Statisticians would usually come up with a survival curve called the Kaplan-Meier curve to illustrate the difference. If the two curves that you see in this graph separate significantly, then you can conclude that this intervention, this drug, or this new technique indeed makes a difference in the life of your patient. This was demonstrated in a clinical trial conducted by Dr. Stoop and co-workers in the early 2000s for glioblastoma. This showed that combining chemotherapy in the form of temozolomide and radiation compared to radiation alone as an add-on treatment to surgery significantly improves the survival of glioblastoma patients. Prior to this treatment, most patients with this aggressive tumor die within a year of their surgery. Based on these curves, you will see that as much as 25% of patients survive beyond 2 years and 10% survive beyond 5 years. Outcomes that were practically unheard of before 2005. An even greater benefit was seen on less aggressive tumors such as grade 3 or anaplastic astrocytoma and anaplastic oligodendroglioma. So you will see the arrows pointing to the curves showing the difference in overall survival and progression-free survival in favor of patients who were given chemotherapy. Of course, just like surgery and radiation, chemotherapy also has its risks or side effects. What's important in making a treatment decision is to make sure that the benefits outweigh the risks. You must remember that chemotherapy affects people in different ways, so that what your neighbor or your relative has experienced may not be the same for you. Nonetheless, listed here are the common side effects from chemotherapy. One can experience nausea or vomiting, constipation or diarrhea, loss of appetite, fatigue, low white blood cell count that can lead to infections, low platelet counts that can lead to bleeding problems, and low red blood cell count that leads to fatigue or anemia. There can also be fertility problems. Hair loss can sometimes be a complication, but not all the time. Targeted therapy, on the other hand, has also its unique side effects, which depends on the target. For example, EGFR or epidermal growth factor receptor inhibitors largely affect areas that have epithelial linings, particularly the skin. So it's manifested as rash, changes in nails, diarrhea, liver inflammation, or lung inflammation, so-called pneumonitis. For anti-angiogenic drugs, which has effect on our blood vessels, less common but serious and potentially life-threatening problems could be blood clotting as well as bleeding. Now, earlier we talked about immunotherapy. We said that immunotherapy works by releasing the brake that the cancer puts on the immune system so that it can fight the cancer. Unfortunately, sometimes in releasing the brake, the immune system becomes hyperactive and also attacks the normal cells, so that it can manifest as a skin rash, sometimes vitiligo, pneumonitis for those with that will affect the lungs, and more commonly, hormonal glands can get affected, leading to decreased hormone secretion from the thyroid, the adrenals, and the pituitary. Now, it is well known that brain tumors are one of the most difficult diseases to treat medically. Despite the wealth of drug development in other diseases, there's only a handful of drugs currently approved for brain tumors. And this is because of the following factors: poor drug penetration into the tumor due to the blood-brain barrier, intrinsic resistance of brain tumors, and interaction with commonly prescribed drugs for brain tumor patients such as steroids and anti-seizure meds. Nonetheless, we have tried to improve on these limitations by looking at other drugs, what we call experimental drugs. Contradicting or contrasting this with standard therapy, experimental therapies have not completed yet the steps to fully prove the efficacy and safety of these drugs or modalities. Therefore, patients on clinical trials may or may not benefit from the treatment being studied. So what is a clinical trial? A clinical trial is a system to improve the results of standard therapy by testing experimental treatments. It is often used for drugs or chemotherapy, but can also be used by new surgical techniques, devices, or radiotherapy, or combined modalities. Its objective is to determine if a promising new drug, device, or technique can pass the test to be declared a new standard treatment. This requires testing the drug's safety and efficacy in a scientific, well-supervised, safe way, while also getting the most information following a written protocol. At the Cardinal Santos Medical Center Cancer Research Unit, we have currently several clinical trials ongoing for early and advanced breast cancer, early and advanced lung cancer, and advanced renal cell cancer. You may call our clinical trial coordinators written on this slide. You may take a photo of the slide if you think you or your loved one's cancer can benefit from these clinical trials. So at this time of the pandemic, how do we keep you safe at our cancer center if you come for consultation or treatment? We want you to know that we have followed strict screening protocols at our triage areas. We follow a no appointment, no entry policy, and we require mandatory RT-PCR testing for all patients undergoing procedures, including radiation, chemotherapy, and blood transfusions. Of course, our hospital personnel all wear level 3 PPEs. So just a few practical tips for those who would like to come consult a medical team for your brain tumor or any other tumor your family member may have. Most important to know what to ask, because it can be overwhelming and hard to remember when you already come for consultation with a deluge of medical information using a language that you don't understand. So bring someone with you or ask someone to join on calls if they cannot come with you physically. Take notes or ask a person with you to take notes. Ask also for written instructions or materials, and repeat the instructions as you understand them so that you can clarify with your doctor if you are on the same page. Ask who is the contact if you have more questions and what is their number or email address. And decide who will be the primary person communicating with the doctor. Is it you, your husband or wife, or your children? Try to keep one designated person to do this. And you can ask also, are you being enrolled in a clinical trial? If you are, what phase is this and what are the goals of the study? If you're undergoing whether clinical trial or standard treatment, what is the treatment plan schedule? After treatment, can you drive yourself? Are there any special precautions? Are there certain food that you're not allowed to eat? And how do you follow up response to your treatment? When are you going to have your next MRI or CT scan or PET scan? And of course, what are the side effects? How do you prevent them or how do you address them? And what do you need to report to the doctor if any of these side effects occur? Who do you call? And can you continue with your normal activities? Can you go to work? Can you exercise? And lastly, you might also want to ask if there is an information on your treatment that you can take home with you in writing. Now, a word of caution. Many of us really go to Google to find practically every question we have on Earth. Remember that to research the basics of your diagnosis and treatment on trusted websites. Among these websites for lay people are your nccn.org or National Comprehensive Cancer Network. You can also go to American Cancer Society. The Philippine Society of Medical Oncology also has a website with very useful information that you can that can guide you along your treatment. And for brain tumor patients, there's also the American Brain Tumor Organization. Remember that the first or top sites may not necessarily be the best sources. So feel comfortable asking about information that you have read to verify its accuracy with your healthcare team. Remember, your medical team has spent 20 or more years studying and training in order to gain expertise in managing your disease. Google, on the other hand, is giving you information it gathered in one click of your finger. So trust your medical team. Thank you.
Thank you very much, Dr. Malu, for that enlightening talk. Very nice tips indeed. And we would like to laud Dr. Malu for leading the way in treating our cancer patients, more so during this difficult period of the pandemic. We have been a witness to this, and they have been doing such a great job. At this point, we will now ask a brain tumor patient to share with us his experience being treated by a multidisciplinary team of doctors. He's an OFW based in the Middle East who was diagnosed with a brain tumor. He eventually decided to have his treatment in the Philippines. From his perspective, let us look at the journey of a brain tumor patient. Let us welcome Mr. Rodel Perez.
Good afternoon. I am Rodel, 45 years old, and an OFW based in Dubai, UAE. A quick background about myself. I have been in the aviation industry for 15 years. I'm working as a department officer for allocation in the operations department for Danata, a global leader in airport ground handling services. I supervise more than 80 allocators, and we are responsible for deploying resources to service the turnaround needs of both passenger and cargo flights operating in Dubai Airport. September 24, 2020, when I was diagnosed with brain tumor. This was after I experienced severe dizziness the night before. Vertigo was the first impression of the doctor who did the diagnosis, so I was advised to undergo CT scan to check if I have an ear infection. Upon hearing CT scan, I initially thought that it's kind of too much for me to do that, considering that I was just feeling dizzy. Nonetheless, I decided to listen to the doctor and proceed with the CT scan. The result came out and the doctor told me that I do not have an ear infection, but he saw some boo-boo in my head. And then he reassured me that there is nothing to worry about and everything will be okay. He then made an appointment with the resident neurosurgeon. And just by the thought of consulting with the neurosurgeon, I started to feel uneasy, but still tried to block any bad thoughts and remained optimistic. The neurosurgeon confirmed that I have a tumor in my head, 2 by 3 by 5 centimeter in dimension, or about a size of a medium-sized lemon. After hearing this, I don't remember what I asked or what he said. It's just like a scene in the movie that everything was a blur and you don't understand any words coming out from the doctor anymore. I then decided to go home and talk to my family first. The doctor agreed and offered to call him anytime if I have any questions. I remember the long walk to the metro, as all sorts of thoughts were coming into my head. What will happen to me? What will happen to my wife, my daughters? Is my life about to change? Upon reaching home, I remember going to bed to get some sleep, hoping that when I wake up, it will turn out to be just a dream. Unfortunately, when I opened my eyes and looked at the table, I was disappointed to see all the papers from the hospital right where I left them. Then it hit me. This is all happening. This is real. As I faced my reality, I informed my eldest sister, Ate Kleng, and my manager in the office about my condition. I remember receiving a lot of calls with encouraging and reassuring words from my friends that day. Later on, my sister and my wife, Alma, discussed how are we going to approach the situation. They advised me to go back to the doctor and asked about my options. Following my family's advice, I went back to the doctor and listened to his explanations. The options that were offered are leave it as it is and do nothing, undergo gamma knife treatment, and lastly, have a surgery. He explained the pros and cons of each option. However, at this point, surgery is still not an option for me, maybe because of fear and other worries running in my head. After the visit, we started looking for options in the Philippines. I approached a good friend in Dubai that has a brother who is a surgeon, and they recommended to look for Dr. Gimenez of Cardinal Santos. Coincidentally, Miss Lucky, a friend of my sister from her previous work, recommended the same doctor. From there, we booked an e-consultation with Dr. Gimenez. The concept of e-consultation was new to me, so I was a bit skeptical if this will be a meaningful session, but I was hopeful. And behold, I was greeted by a big smile and a very calming voice from Dr. Gimenez. The mood of the meeting was very positive that set my spirits high. He answered all our queries and cleared our doubts. So when he recommended to do a surgery without hesitations, my wife, my family, and I agreed. The date of the surgery was set to happen from October 19 to 23. This was all happening during the peak of COVID when there were travel restrictions. So the process of entering the country was very challenging. On top of that, I had to undergo quarantine. So after my last day of quarantine on October 21, I immediately went to Cardinal Santos to do some tests in preparation for my surgery. I finally met Dr. Gimenez in person a day before the surgery. He introduced Dr. Rañoa and other members of the team who will be there in the operation. Seeing him and the rest of the team brought me nothing but joy and hope. All of them made me feel confident about the procedure. At this point, I've surrendered myself to God and allowed Him to take over for whatever will happen. The day finally came, and I remember having a good sleep night before the operation. I was taken early in the morning, and the last thing I can remember before I was put to sleep was having a friendly chat with the doctor inside the operating room. Hours after the operation, I woke up in the recovery room feeling thirsty. The attending nurse was kind enough to attend to my needs to make me feel comfortable. I remember even calling my wife as per my request. The surgery was a success, and Dr. Gimenez mentioned that the team did not even encounter any hiccup throughout the whole procedure. He mentioned that it was a beautiful day. Everyone was relaxed and they took all the time they need. The recovery was a breeze, and I was released from the hospital after 7 days. 11 days post-surgery, I was already walking, though my legs are still wobbly. After 2 months, I was back in Dubai and was waiting for my clearance to go back to work. I have to wait for 2 more weeks to get clearance from our company doctor and need to undergo a similar test that pilots do. I passed the test with flying colors. I considered the whole experience as a blessing. I realized that God works in mysterious ways and blessings can come in any form. Who would have thought that a simple gesture from a colleague pushing you to go and visit a doctor can be one of them? If I ignored that advice, I could have not known that there is something wrong. If the doctor in Dubai did not diagnose me thoroughly and send me for CT scan, I could have not known that I have a tumor. If it was not diagnosed early, who knows what problem it can bring later in my life? What are the chances that a friend from Dubai and my sister's friend have the same doctor to recommend to help me save my life?
Thank you very much, Mr. Rodel, for being very gracious to share your story with us. Your message of gratitude means a lot to me and my team, and believe me, it really keeps us going. So we hope that through your story, we have shed light on the importance of not foregoing treatment for one's sake and well-being. And lastly, to emphasize that these services are at the disposal and within reach of our kababayans. So with the roster of our speakers and the wealth of insights and learning shared, we will now open the floor to your questions. And I know we have several already, so let me read the first question here. So I'll throw this question to Dr. Ted Vesagas. This is from Mr. Rory Visco of the Business Mirror. Is it really becoming a trend to consolidate the various disciplines related to neurosurgical, and even psychiatric, psychological treatment into one institute? What are the advantages and on the flip side, the disadvantages? So, Dr. Ted.
Well, we're not really consolidating. You think I'm still with the Department of Surgery, so are you. Dr. Malu is still with the Department of Internal Medicine. So we're all still in our, in our mother departments academically. What we do here is we look for the intersections of our interests, and where those intersections are, we can shine and help each other. So maybe we're not really consolidating because it's a multidisciplinary thing. We all come from different disciplines now. Though administratively, we actually belong to different departments. The advantage, what we've talked about kanina, about being able to put all our, put all our specialties to bear, bring our, our strengths to bear on a problem. For me, the disadvantage would probably be the amount of time we have to do for this, because this doesn't happen in a vacuum. We still have to spend time for this, and in a sense, that's a disadvantage because it just, you do this outside of your clinic time. We have to make time to come together and to do these things. It's not really a disadvantage. We enjoy coming together, but it does. If you think about it, this could be time that you could spend elsewhere. The second part is stature. So the stature is a loaded word. I think from my own experiences, having done, maybe for you, Mike, having done fellowship abroad, I think, and our patient who's an OFW from Dubai, I think we are some of the best in the world. We just don't give ourselves enough credit. I think the neurosurgeons, the surgeons, the Filipino surgeons, actually pretty good from what from my own experience abroad. And as far as skill and competence, I think we're really second to none. Where are we? Saan tayo saan tayo na dedehado? We are a third world country. We don't have all the toys. We don't have that strength of research, though. It's nice to know that we are coming up on that. As far as research is concerned, we're gaining there. We're getting there. But maybe that's where we're a little behind. But I think if you're going to ask us about how skilled we are or how competent we are, I think we're pretty good. We're up there. The third question has to do with advancements in CSMC. I think this has been talked about now by Mike, by Gilbert, and Malu, Dr. Malu. So I think that's been answered through all of our lectures. Mike?
Thank you, Dr. Ted, for answering those questions. Next question, I'll throw this to Dr. Malu. There is a lot of contradicting information on the internet about tumors, but a lot of people choose to search. Wait. Sorry, I lost that. But a lot of people choose to search up this information in an attempt to self-diagnose or self-examine themselves. How can we encourage Filipinos to seek medical advice over checking their symptoms on the internet? Second, how do we curb the growing apathetic behavior towards early cancer detection because of this? Third, what can we advise people who rely on the internet for checking their symptoms? Dr. Malu?
Yeah, thank you, Mike, for that question. Okay, so as I have already discussed in, I think, the last portion of the talk, the internet is really a very powerful tool, but unfortunately, it does not give you the big picture. It gives you bits and pieces of information, but because you're not talking to a doctor, you don't really know how to put them together. And so you don't really know what to do with that information that you get. So it is all right to search the internet. As I mentioned, it's better to go to reliable sources. But at the end of that research that you make, you bring it to the doctor and verify that information and see whether whatever you have gathered applies to you. And obviously, the internet cannot treat you. Google cannot treat you. It can only give you information. So even though you find out that you have, for example, a tumor, and based on what you have gathered, it may probably be harmless. You won't really know whether it's harmful or harmless unless a doctor examines it, takes a sample of it, brings it to the laboratory for biopsy, and then that's the only time you find out whether it's benign or malignant. No, so because of that, it is very important that you consult a doctor, that you consult your physician, and also ask your physician to refer you to the appropriate specialist. Now, when it comes to cancer screening, the Cancer Center in particular, and as well as the several organizations, including the Philippine Society of Medical Oncology, are very active in promoting cancer screening. So every month we celebrate a particular cancer. For example, October is breast cancer month, and that's the time we really promote mammography and early screening to be able to detect cancer early so that we catch it at the time that it is still curable. So what is very important to emphasize is that cancer does not have to be deadly. It does not have to be a death sentence for any of us, as long as we are vigilant, as long as we catch it early and treat it appropriately.
Thank
I
you.
answered the question. Is there another third question that I didn't answer? Or
Let's check that, Madhu.
Yeah.
The third question, what can you advise people to rely on? You answered all questions.
Yeah, all right. Okay.
Okay, thank you, Malu. Okay, so next question. Because of Filipino stigma, as well as lack of education on the importance of getting regular checkups, many Filipinos dismiss symptoms that might be signs of a deadly disease. How do we convince Filipinos of the importance of getting themselves checked for these possible issues? Dr. Ted, can you take this question, please?
Yeah, I think Dr. Malu answered this. No, so the doctors are professional organizations do promote cancer awareness. But the other thing about this is it's a cultural thing, at least probably for Filipinos who don't want to bother their relatives with what they're feeling. I see this a lot with some patients that they don't want to bother their wife or bother their kids about something they're feeling. So they keep it, worrying about maybe it might disrupt the family or cost something. So that it's a cultural thing. I don't have an answer to how to do that, but I think the first step really is making people more aware, and our professional societies are doing that.
Thank you, Dr. Ted. Next question. How would you know which is the better option? Dr. Ted?
Yeah. Actually, there's no...
Oh, I'm sorry. Yeah, go ahead.
Yeah. There is really no better option. I'd like to think of the gamma knife and surgery as complementary to each other. There are times where there are situations where a gamma knife would be a good, the primary option you'd like to pick. Maybe for smaller tumors, it'd be nice if we have a picture of that, but small tumors which are deep inside the brain, which are still not which are still not affecting the brain so much, and you'd like to be able to treat it without injuring inflicting further injury. So this is where the gamma knife is strong. If the tumor is already very big, really the better option, especially if there's compression of the brain, the better option might be open surgery. And there are times, like Mike, we know this, there are times when we have to use both modalities to be able to address a problem.
Thank you. Dr. Gilbert, you'd like to make additional comments regarding this question? Which is a better option, gamma knife or open surgery? I mean, speaking from the open surgery side.
Yeah, well, there are certain tumors that are better gamma knife, and there are other tumors that are better excised, no? And still, no, the others naman would respond better for chemotherapy. So basically, there are different factors that come into play. Number one, the most important, I think I mentioned it in my lecture, is the histopathology. So some tumors, let's say gliomas, may not be applicable for gamma knife radiosurgery. So histopathology is really plays an important role. As I've said in my lecture, specific or different tumors would have different types of treatment. No, it can be surgery alone or a combination of the different modalities. And then Dr. Ted mentioned size. No? One of the limitations of gamma knife would be the size. If you have a huge tumor that has mass effect, I think that's the time when surgery becomes a better option. Another factor is location. If you have a deep-seated tumor, and I'll exaggerate, no? If it's in the brainstem, you don't want to touch that with surgery. Just the same, if you have a very superficial tumor, it's just there and it's a benign location, and you can actually afford a total cure by doing surgery, then I think it's really the best option. And then probably number can also be a factor. Of course, you have, I'll exaggerate again, probably if you have 14, 15 tumors, surgery will not really matter if you take out one or two. Obviously, you cannot take out all of the 14 or 15 tumors. Then radiosurgery or radiation can be the best option in this scenario. So,
thank you. Thank you, Dr. Gilbert. I'll just go back to one question here, and I'll direct this to Dr. Malu. Ordinary Filipinos view cancer treatment as something only rich people can afford, which deters them from seeking both medical advice and medical treatment. What can be done to change this mindset? And does Cardinal Santos have any programs in place that can help patients afford these kinds of treatments?
Thank you, Mike. Thank you to whoever asked that question. So at Cardinal Santos Medical Center and at the Brain and Spine Institute, we have the Philippine Alliance for Brain and Spine Tumors. This was inaugurated at the same time as the Brain and Spine Tumor Center. And this foundation is helping and has helped hundreds of patients get free treatment, even free diagnostic modalities such as MRI. So, and aside from this, there's also the Cardinal Charities Foundation, which also helps indigent patients get big discounts and even actually free their free procedures, especially those that are admitted under our residence service program. Outside Cardinal, we also help the patient get support, financial support from their local government units, the Philippine Charity Sweepstakes Office, as well as DSWD. So what I always tell my patients is that if there's a will, there's a way. Lack of funds should never be a deterrent to seeking medical help, because we, your doctors, will find ways. Believe me, we will find ways to help you. We will actually even call drug companies to help get free medicines and stuff like that. So just do that first step of consulting, and we will deal with the other problems later on. Even if it's Cardinal Santos, it's a private hospital known to cater to the A and B crowd. Even our indigent patients can get help from us.
Thank you, Malu. Now, the next question, Malu, has to be answered by an oncologist. So please take this as well. Can developing lumps, tumors, or cysts be avoided? What do Filipinos need to do long-term so that they can avoid developing these?
All right, so it depends, no? It depends on which organ you're talking about. So there are, of course, certain tumors that are linked to our lifestyle. For example, lung cancer. You can certainly avoid developing lung cancer and even other cancers of the head and neck, no, particularly the vocal cord or the nasopharynx, if you just quit smoking or don't start smoking at all. Okay, so colon cancer, for example, they say we can prevent colon cancer by getting, for example, an early colonoscopy, at the screening colonoscopy at the age of 50 years. And if the doctor detects a polyp, a pre-malignant polyp, and takes it out, then you prevent developing colon cancer. Aside, of course, from maintaining healthy weight, exercising, and proper diet, a well-balanced diet rich in fiber. So there are many things that you can do in order to prevent developing certain types of cancer. But brain tumors, for example, glioblastoma, it is largely a genetic disease for which we have no preventive measure. Okay, not avoiding using cell phone or whatever. These things do not prevent brain tumors. So it really depends on what tumor you are considering in this particular question.
Thank you once more, Malu. Dr. Gilbert, I'll throw you the next two questions. There is a rumor being spread around about tumors that kapag mas malapit sa utak, mas nakamamatay. How true is this statement, and what are your thoughts on this?
Not necessarily true, and I'll answer that by giving an example. Let's say you have a benign tumor, and the key word there is you have a benign tumor in your brain, and you have a malignancy. What? Ilayo natin, let's say a pancreatic carcinoma, which is what we know na it can be very quite, aggressive. So just by comparing the two, kasi the premise there is wrong. So the premise there is the nearer the tumor sa brain, it's more lethal, it's more malignant. So that by itself, I think it's erroneous. So again, I've emphasized this quite a number of times. The histopath is really the key here. There are tumors that will give you a clue that it may be benign. Once in a while we hear that if you can palpate them, but the thing is with CNS tumors, you cannot palpate them. You will develop symptoms, and you really need to consult the specialists, neurologists, neurosurgeons, oncologists, and they are the ones whom you really have to rely on. What imaging to get, and I think I hope I was able to answer the question.
You did, Gilbert. Thank you. Now, since you were touching on benign brain tumors, the next question is, if I have been diagnosed with a brain tumor, is it really necessary to remove the tumor even if it's benign?
Not always. Again, I'll answer that by giving examples. I actually have a couple of friends, even a relative, whom I am observing for the past so many years, and they have benign tumors. One of the more common benign tumors that I observe, and I'm sure the other neurosurgeons do observe, is an arachnoid cyst. So that's a relative of mine who's from the States, who would come to the Philippines. This is pre-pandemic, of course, to get an MRI and show me an MRI. So that's his routine. I've been observing that cyst for the longest time. And even a friend of mine who has a meningioma, again, this friend of mine is a nurse, works in the States as a nurse, and she has the tiniest meningioma. It's a benign tumor. And of course, when you work as a nurse in the States, you have access to all those like gamma knife. So she's free, she can get it for free, and yet she doesn't want to. So I've been observing that for so many years. So generally, benign tumors that are asymptomatic, to say they're not doing anything, you can observe them. So it will again depend on the histopath, the size, the location of these tumors. That's all, Mike.
Thank you, Gilbert. Dr. Ted, could you take the next question? Even in the smallest of tumors can incite anxiety in someone, making them fear the worst. What can you advise patients who have discovered they have a tumor and are worried about getting diagnosed with cancer or are already diagnosed with cancer? What do family members of people who discover they have a tumor, whether benign or malignant, need to know to help them? Dr. Ted? Dr. Ted, can you take that? I think
Yeah. So if you have a family member who is diagnosed with some sort of a tumor, I think the first thing you have to do is get data, find out more information about it. Visit your doctor and find out what the problem is, what exactly the problem is, what are your options for treating. And that will help alleviate some of that anxiety. What can you advise patients who have discovered they have a tumor and are worried about getting diagnosed with cancer or already diagnosed with cancer? I think this has to do with anxiety. No? That's a tough question because that will vary from person to person. I have to ask Malud, we're multidisciplinary. How would you deal with this? I'm thinking you have more patients who have more anxiety.
Sorry. What is the main question? Sorry.
How do you deal with patients who have anxiety about having a
Anxiety.
tumor? Yeah.
Oh, okay. It really boils down to establishing a relationship with the patient. Now, once you have established a relationship with the patient, you kind of have that ability to calm them down and make them a little bit more objective about what the steps that they should follow in order to determine whether this is really something they should be anxious about, or it's just something that that can actually sleep off. No? So that's first and foremost. And secondly, there's always especially amongst Filipinos, what I find very useful and very actually it really works for them is praying with them. You know, when you pray with them, somehow it soothes their spirit and it calms them down and it gives them a clearer mind now to understand the pros and cons of certain procedures and also the realities of a certain diagnosis. And then again, thirdly, I think it's also about the confidence that the doctor has. Because sometimes if the doctor, sometimes some patients just tell me some doctors also can be very anxious. They come across as anxious. They make patients afraid of their diagnosis, a bit threatening. So it also helps to be on the calmer side when you discuss certain especially a cancer diagnosis to the patient. It always pays to give them that hope. Now, even if it's cancer, something can be done.
Thank you, Malu. Thank you, Dr. Ted. If you guys will allow me to add something, the first thing I always mention to a patient and his family, his or her family, is that the first session, the first meeting, is for me to be able to educate them about their disease. I think it all starts with educating these people, our patients. Then from there on, they start being less anxious, they start understanding more, they get to know about the natural history of the disease. So I think that really calms them down significantly. So the next question will be directed to the superstar of our multidisciplinary team. We always emphasize that the star of our team is really our patient. So Mr. Rodel, please answer this question. Considering that you already have an option in Dubai, why did you choose to do the procedure at Cardinal Santos Medical Center?
Okay, thank you for that question, Dr. Gimenez. First of all, before I answer the question, I was taking notes on what Dr. Luisa was saying about getting diagnosis, not a death sentence. If there is a will, there's a way, calming your patients. So I can really reflect on all these things. This is the feelings that I had initially. So I thought it was a death sentence for me already. And then I looked for options. So I thought it will be a problem for me to cover the expenses, but it was not. It did not come to a point that we have a problem with the financial. So everything come into place. So when we approach Dr. Gimenez as well, the first thing he did is to educated us, and he calmed our family, and then we understood what are we going through. Okay, so I'm just happy to what you call this express that gratitude to the team. And okay, so to answer the question, I already have an option to do the surgery in Dubai, but I still choose to be here. So our consideration is number one, I'm alone staying in Dubai. We thought of the recovery, the support system for me when I post surgery, and then we look at the expertise. So we did our research, and we found out that in our country we have the best doctors that can cater for this kind of tumor, or can cure us. So it was after we have that first meeting with Dr. Gimenez, we confidently decided that I will be here.
Thank you once more, Rodel. Next question, Dr. Gilbert, I'll ask you to take this question. From the story of Mr. Rodel, vertigo can be a symptom of brain tumor. How do you know if you have to consult an ENT, a neurologist, or a neurosurgeon for this symptom?
You can actually consult any of them. No, there is no best. I can be biased, but I think that's a wrong notion. No, there's no best doctor for this. There are really overlaps. So specifically for Rodel's issue, no, I think the fact that he was sent to us, we ended up with a happy story. No, he went to the right doctors. No, the first doctor, if I'm not mistaken, was an ENT, and if not for that guy, he wasn't able to get a CT scan, which probably is a reason that led him to visit a neurosurgeon. And you know, if he or if he made a wrong consultation, he probably wouldn't end up this way, you know, having a successful story. So there are a lot of overlaps in our fields. Let's say here, you know, we're talking about brain and spine tumors. Now we have an oncologist, we have neurosurgeons. You can even add in neurologists. You can even have your orthopedic surgeons for spine. No, so it's not just your neurosurgeons and your medical oncologists. Okay.
Thank you, Gilbert. So whoever you see first can actually direct you to the more appropriate specialist as well. Okay, so Rodel, were you raising your hand?
Yes.
Yes, Rodel, go ahead.
Doc, I just want to add on what Dr. Gilbert was saying. In my experience, I think one of the reason for me getting diagnosed earlier is I was honest enough to tell the doctor what are the symptoms. I describe it clearly. That they gave, I gave them the what they call this a clear picture of what they need to check. So I think one secret is to be honest with yourself and make sure you're telling the real story to the doctor who's doing the diagnosis, and try not to be afraid.
Thank you, Rodel. That is very important. Being a good historian is essential to us doctors. Okay, so thanks again, Rodel. Next question, Dr. Ted, can you take this? I think these two questions are related. Let's say I had a CT scan 5 years ago, but I suspect having a tumor now. Will it quickly grow with the first scan? Or is it possible that it develop only after the first scan? How fast can a brain tumor develop?
I think that depends on the brain tumor. No? If you have a benign tumor, like a meningioma or a schwannoma, it may or may not grow so much over 5 years. I'm assuming in the first scan they saw something. 5 years, it may or may not grow. Some meningiomas are really very indolent and they don't grow at all. But if we're talking about something else, no, a cancer or maybe a lymphoma or one of those things, and that can develop very easily within a scope of 5 years or even less. A few months will be enough for some of these tumors.
Thank you, Dr. Ted. Okay, so with that, I think that's the last question. So with that, we formally conclude this afternoon's Webicon. This would not have been possible without the collaboration of different departments in our hospital, our media partners, and most of all, our valued patients, partners, and guests. Thanks so much, everyone, for making our Webicon a success. And I saw in the chat box some of our patients sending messages. We thank you once more for being very gracious and for valuing us, your doctors. To our speakers, Dr. Ted Vesagas, Dr. Gilbert Rañoa, Dr. Maria Luisa Tiambeng, thank you so much for spending your time in making this 9th Webicon series happen. We hope that we were able to enlighten and motivate everyone to never forego medical treatment as we ensure everyone's safety in providing world-class medical care. Always remember, here at Cardinal Santos Medical Center, you have a village of medical experts working hand in hand to save lives. Let us know your Webicon experience by logging on to www.menti.com, inputting code 3803-8109 to evaluate this session and to let us know your suggestions and recommendations. You may also access the evaluation, which will be emailed to you shortly. Before we finally end, we will be promoting everyone to be panelists, so you can open your videos and turn on your cameras for our photo op. And we enjoin everyone to smile. It has been a good afternoon. Okay, thank you. Rodel, thank you once more. I saw Rodel this morning and he's perfectly fine. His MRI is still negative for tumor. So congratulations and enjoy the rest of your stay here in the Philippines because he's here for a 2-week vacation. So with that, we'll now bring you the Cardinal Santos Medical Center here. Thank you.
Matatatalas na